Good morning, everybody, and welcome to the Social Housing Roundtable. It's great to have so many people with us already. We're looking forward to a really interesting session, and judging by the recordings we've had recently, we probably have lots of people following up as well. So if you are following us on Catch Up today, great to have you with us as well. My name's Matt Baird. I've been running the Social Housing Roundtable now for nearly 3 years. The idea is to bring people together in a space where we can talk really openly and authentically around a huge range of topics. And as you'll have noticed from today and from yesterday, this week's themes is really around mental health and mental well-being. A theme which it's Learning Disabilities Week this week. I know we've got an awful lot that's happening kind of across the space in that arena, but I think most importantly, we're in a world where mental health is talked about more openly than it probably ever has been. So it's great to have these sessions on with us this week, and I'm hoping that today's session will be really informative for everybody who's able to join us. So on to today. Now we've got 4 speakers today, so we are going to get started relatively swiftly. Delighted to have Vicki Brownhill with us from Midland Heart. We've got Kelly Plant who's with us from the Black Country Mental Health Trust, who I've got job title here, Operational Delivery Manager in Community Transformation. I'm glad you didn't have to put that on some kind of job application form, because that would be a really long one. We've got Suki Kaur, Head of Business Improvement from Chad, and Sureya, who's my key contact at Walsall Housing Group and helps put all of these together, and has helped sponsor this year's WHG series. So massive thank you to Sureya. But we're going to start with Vicki. Vicki, Head of Housing Management, Interim Head of Housing Management at Midland Heart. So I'll pass over to you. I'm going to be showing your slides this morning. So I'll pass over to you to get started, and then I'll load up everything on my side so that we can get the session going. So I'll pass over to you.
Brilliant, thanks, Matt. So yeah, I'm Vicki. I work here at Midland Heart, Interim Director of Housing currently. I'm going to just do a bit of scene setting in respect to some of the things we're going to talk about across the colleagues that's on the call today around the topic of building mental wellbeing in our homes. So I thought I'd just kick off with some stats to start us off with, really, in terms of setting the scene. I just think the session's just coming through. Brilliant, thanks, Matt. So yeah, just moving on to the next slide then, just looking at some of the stats to put this stuff into context, really. We're aware that children and adults living in households with the lowest 20% of income are 2 to 3 times more likely to develop mental health problems. Again, looking at, and this is some sources of information from the Mental Health Foundation, looking at unemployed and economically inactive individuals also have a higher rate of common mental health problems than those employed. We're aware that employment is beneficial for mental health for a range of reasons. However, we also need to consider the type and quality of work that people do. We know that often people can be in low paid employment. We can also have unstable, insecure employment as well. So people who are, 0-hour contracts, that sort of thing. And these are the sorts of things we need to be thinking about as well when we look at our tenant basis, because ultimately these issues can also pose problems for people around their mental health when they're concerned about particularly like the cost of living issues that they've got. Rents rising across the sector as well, that sort of thing. So although employment's general, is beneficial for people, we just need to also think about the quality and the nature of work as well. And another stat to think about is around housing benefits. So, and I suppose any of the benefits that we get now across the sector around universal credit, etc. We need to be thinking about the people on benefits are more than twice likely to have common mental health problems than those not receiving them. So when we think of this in the context of our tenant bases, that we've got people on that are unemployed, people are on low incomes, and we're housing people with the greatest need. All of these things are things to think about in respect of why this is a really important topic for housing providers. Just on to
so Nicola, in the start, I don't know how you.
Sorry, I had a bit of feedback then, I apologise.
No, sorry, someone's also watching the news, so I just muted them.
It's all right, not to worry. Just on to the next slide. Thanks, Matt, if that's all right. So again, this was a bit of a study I thought would be useful to put the housing side of things into a bit more context as well. So this, issues across the private and social housing sector. So it's important to think about this from that perspective. There's issues around people living in, not living in safe, stable or suitable accommodation. So this was a survey that Mind did, around 2,000 people that they surveyed about their housing situations. What that told them was 80% of people with mental health problems lived in housing that they felt made their mental health worse. And we've got then 40% of people who experience stigma or discrimination in the place that they live. And then 66% of people were concerned about the quality as well of their housing. So this is people with mental health issues that felt that the quality of their home wasn't good. So again, if you think about this in the context of where we are now across the sector, we know that the white paper, the social housing white paper, we know the Regulation Act sort of cited that 1 in 4 people had a mental health issue, or that's what was estimated. And it highlighted really the important role that housing providers and social landlords in particular play in supporting tenants who present with mental health issues. It also discussed around the issues or the interdependencies around, in some cases, we've got perpetrators of antisocial behaviour who also have mental health conditions and or drug and alcohol issues as well. So again, this is another area of work for us to be mindful of in terms of how we address those issues really. And that led to really thinking about the professionalisation agenda. So thinking about really, are our housing staff equipped really with the right knowledge, skills, in order to work with people with mental health conditions and make sure that they get the, understand best practice and how to support individuals to sustain their tenancies, and working with different signposting agencies and providers as well. Just moving on to the next slide. Just wanted to talk about this in respect to the context for us at Midland Heart, and again, others will have other stats around this, but we've got 3,586 lead tenants who've told us that they have a mental health condition, which is around 10% of our overall tenancies. However, thinking about the sort of work we're doing around data and improving information on our systems really, and the vulnerabilities that we're coming across, we do expect this to be much, much more. And we know social housing provides accommodation for some of the country's most vulnerable individuals. What we know also is often people will move into areas that perhaps they didn't live in previously, perhaps where, new locations, new accommodation, and sometimes that's where we have the issues around support not being in place in those areas, or certainly the support networks and services not being around. So we need to think about all of these sorts of issues really in respect of how we work more closely with partner agencies, with health services, etc. And in terms of the housing ombudsman, again, this is not a surprise to anyone who's working, in the sector, is around sort of needing to evidence the support that we're offering to individuals, what adjustments are being made in terms of supporting them to address, the concerns that they raise with us, but also about how we ensure that they're getting the right service, they've got, it's fair service, and they've got access to services, and we're helping ensure that we're sustaining tenancies. So I'm just going to consider now some of the more specific issues for us to think about before we move on to the other partners that are going to speak today. So key area for us in respect of social housing providers is antisocial behaviour. And I've broken this down into the two aspects really, which I think mental health conditions and issues can arise with, because we've got the impact on victims and complainants. Now, victims and complainants themselves may suffer with poor mental health, or as a result of the issues that they're experiencing, that can be adversely affected. So again, antisocial behaviour can seriously affect customers' lives. Another thing I think we all need to be mindful of is victims can feel unsupported. So we can be often doing things with perpetrators, and there will be elements of information that we are unable to share for confidentiality reasons. But also it's about how people feel that things are, perhaps going on longer than necessary or what they expect. And I think this can then lead to people feeling unsupported and dissatisfied, which then subsequently can lead to a rise in complaints to our organisations now for our handling of antisocial behaviour issues. And again, as I said, there's a greater expectation of the housing ombudsman now to make sure we are doing, taking all available actions really, making sure we are doing identifying vulnerabilities and signposting and supporting individuals where that's needed, necessary. Obviously, antisocial behaviour left unaddressed can deal with the impact on neighbourhoods and can cause low demand. We've got experiences at the moment as an organisation where we are we're having to think about how we relet, or can we relet properties where we've got issues in areas, because we don't want new people to move into our properties where there are ongoing issues around legal actions and cases that are going on because of the impact that can have on individuals. And again, things like anxiety, depression and those sort of conditions often comes to, you know, the fore really in respect of complainants that report issues to us. So just on the flip side then, in respect of the perpetrators, this is obviously, as I mentioned earlier, where we've got tenants that perhaps have unmet needs or undiagnosed needs, and or coupled with other things like drug and alcohol issues as well, which can cause, you know, impact really on their ability, impact on neighbours and their ability to sustain their tenancies. But the upshot of that is, obviously, if we're working with individuals to change behaviours or to try and support them to change, and that doesn't happen, because we've obviously got a balancing act here in respect of our victims and complainants and the duty we need to provide to those, there is a risk that we end up with people in the legal legal action enforcement area, and ultimately could become homeless if evicted. We've then got the close link around ASB and crime. So you've got things like, you know, vulnerable individuals who could be perpetrators because of nuisances in their home. You know, there's a risk of them being abused, exploited, etc. As well. So again, it's just being mindful of those issues, and again thinking about how things can escalate, really, how sometimes neighbour disputes can also be linked to sort of mental health conditions and issues. And again, if things if left unaddressed, things can escalate into stuff that's much more serious. And then the final slide, which I just want to cover off really, is some of the issues around that housing providers find around other sort of conditions, really around, you know, again, so perhaps depression, low mood, hoarding conditions, and there's a whole range of different things that can come into play here, really. But the upshot for us as landlords is about how then, you know, we have poor property conditions, which no one wants. We certainly don't want our tenants living in such conditions, really. It can lead to poor self-care, unsanitary conditions. We've got our landlord functions and the things we need to do, our responsibilities, and we must do this. And again, we've got all our sort of regulations around this, around carrying out repairs, planned maintenance, gas servicing, etc. So again, these are why we must think about how we work in partnership and join the dots with all of these things, really, in respect of why people might not be letting us in their homes to carry out such you know, such services. There's a risk of fire and health and safety risks, and again, I've talked about some of those there around things like hazards as well. So, you know, we want to make sure people are living in quality, decent housing. Obviously, hoarding as well, and not getting into homes to check conditions. We've got the whole array of area around damp and mould, and making sure people, you know, that's not an issue for our tenants, and we're dealing with that effectively. And of course, we find certainly quite often that where we've got hoarding in particular, or certainly poor property condition issues, it does lead to those access issues for us, which again, if we're unable to resolve through support, through making contact with tenants and encouraging them to let us in their homes, can then ultimately lead to legal action for us needing to do get into homes in order to fulfill our landlord functions. So I suppose it was just really my role here was setting some of the scene in terms of some of the things, the considerations that we need to have. And I'm going to hand it over now, if that's okay, Matt.
It absolutely is, and thank you very much. I think it was really important for us to really kind of highlight why we're here in the first place, and actually some of the big problems we have going on. So we're going to bring in Kelly. Kelly, I'll leave you to introduce kind of exactly what your role entails at Black Country Housing Group, at Black Country Mental Health Trust, and I'll leave you to kind of share some of your slides. So I know you're on mute at the moment. Do come off, and we'll pass over to you.
That's wonderful, thank you. And hello everyone, my name is Kelly. I work in the adult division within community for community transformation, looking at how we can transform from a systems wide. So I've come to present something I think you might find helpful, but obviously I can come back to future, or you can contact me with any questions, queries, or being involved in the work, because we do want it to be systems work. So hopefully you can see the presentation I'm sharing with you. I can't see any hands or anything like that. So any queries, just let me know. So if I just move forward, this, I don't know whether you've seen this model, but this was, so about 4 years ago, I believe, that the community transformation was launched. I've been involved from last year. This is the model that kind of we got co-produced across the system, with people who use services, with carers and the wider citizens as well, to say, what do we need? What does transformation look like for the Black country? And as you can see, I'll just walk you through some of the aspects here. So the big orange bubble, that's advice and support to live well, is very much centered around well-being and keeping people well at home, in their communities, but also providing good early intervention and prevention of people deteriorating or getting into a situation having severe mental illness. As we progress through the tiers, because it is a stepped care model, we look into Tier 2 is how we can support people to have care and treatment for people with severe mental illness. Things such as people with psychosis, suicidality, linking to a mental illness such as depression, people with personality disorder, schizophrenia, bipolar, those sorts of conditions, and how we can care and treat them in formal services. Tier 3 is very much about adding on a more complex needs, where we've got to really assertively engage, rehabilitate people, people with really complex personality disorder, which need more intensive support. And then we add on intensity about crisis care and then inpatients, which is 0.5. So it's very much around stepped care model. The bubbles, as you can see, are purposefully at the sizes they are because investment needs to go in at prevention and early intervention. It's something that we haven't really looked at doing historically or been very good at doing. And what we recognise is that the voluntary sectors and faith communities are really, really essential at helping people stay well. But sometimes what we've been is very, very separate from that. We've had formal services, Black country healthcare, for example, and then everybody else. And from a health point of view, we've got to become more integrated, and it's basically looking at everybody's issues, like what Vicki has gone through earlier, really. Mental health conditions don't happen in isolation. You're not just mentally unwell and you're over here. You touch absolutely every services, including housing. So it's massively important we all integrate. Year 1 was very much around how do we change formal services to be as responsive as we can be in the 4 localities. So in Sandwell, Walsall, Wolverhampton and Dudley. And we recognised as a step 1 last year, we needed to change our services to be in structure to enable that pass-through of services so that we can support people with severe mental illness. So each of the areas went through transition. So that crisis now goes directly to crisis home treatment team for urgent referrals via telephone. Primary care mental health teams have been set up in each of the localities that link directly to GPs to support people to be assessed at GPs, but they are really closely integrated with our community mental health teams who provide more intensive support for people who have got serious mental illnesses. And what we need to do, however, is to ensure we've got good patient flow so we can step people down safely and effectively when they're at a stable level, but can step people up when they're not so stable and we've got really complex issues. So historically, our access timeframes have very been much within an urgent framework is we'll respond within 72 hours and non-urgent within 18 weeks. What we need to change through the national directives and the long-term plan is to actually respond quicker, and rightfully so. So if a referral comes through as urgent, which I'll go through in a moment what that looks like, that we've got to really provide that support and services within a 24-hour response, or that can be within 1 hour to 24 hours response, depending on the teams and the need. And then non-urgent, that people get to a point of having some care in place or an outcome or intervention within a 4-week window at point of referral. And that's kind of what we're doing, is setting up the formal services to support us achieving those access frameworks. So what does stepped up care look like? How are we interpreting that model in day-to-day practice? Now, this is historically what stepped up care looks like. And as you can see, the frequency of need should be lower for our more intensive supports and high at our kind of preventative informal services. So we've got to look at how do we provide resilience to people? How do we support wellbeing? How do we support people to identify that something's not right and can help support self-care, self-management? But then if it's stepping up, there's also lots of voluntary sectors, faith leaders, community assets that do a lot of care in the community that really supports mental health and wellbeing. And there's some magnificent services out there that haven't got steady funding streams. They've got paid through the lottery, for example. So it's not sustainable. So what we've done in each of the localities is put in a consortium where we've got sustainable funding for a group of voluntary sector services, and we're aligning and integrating with them as well to support that informal service provision, keeping people well at home and preventing people deteriorating. Stepping back into formal services, we now have primary care mental health teams. Historically, we've had that in Dudley and Walsall. We haven't had that in Sandwell and Wolverhampton for a very long time. And they are teams that work really closely with GPs and PCNs to support the gap between talking therapies and secondary care services, so that people can feel supported to self-manage, look at safety planning, how can we help brief interventions potentially to support people early doors. And that's a really quite fast-paced service that people go through. Then, as you can see, stepping up, we've got that community mental health services then. What we have in each of the localities is our CMHTs, as they're called, old name, new service. And they wrap around each of the PCNs. They've kind of split into north and south to support the work. And it's about how we support and care manage and patients based on the interventions that they may require for a medium longer term point of view, with a goal of stepping people back to GPs, back to their communities without that support. So it's very much based, again, on building blocks of how do we treat, support and provide interventions for people with severe mental illness. And then obviously people can sometimes stay within formal services because of the level of need is so much that they can go to long stay care, supportive accommodation, to support and sustain that long-term care, or can actually go into hospitals. A national ask is that we don't put people out of area, that we keep people local, but that very much is dependent on local provision being there. And sometimes that's not about like, that's your problem. No, there's a supportive accommodation. This is a person you need to look after. It's about all of us that being a part of that person's care package. And that's both from a formal and informal point of view. So what's it look like? What does the referral pathways look like? And how would we step people up and down? So we do have, obviously, if it's emergencies and people need emergency response, we have to go through 999 because that's the imminent risk of death, imminent risk of harm. Urgent pathways with our crisis home recovery teams is about an urgent response where there's a significant risk. So there's a high risk of harm to self or others, or there's a high level of distress, and the absence of capable support is there. This is where we have our crisis home treatment teams. They accept professional referrals via telephones. As you can see there, we've also got the 24/7 helpline that was put in I think it was during COVID or early COVID, and that can support people self-referring. If we don't know what pathway somebody needs to be and we need some support, we can go through that 24/7 helpline and they can navigate people to the right place. Another service that was developed through transformation is the Recovery College. And this is around, as it says, it is a college. It's how we support people. It's developed and co-produced by people with lived experience as well, and managed people with lived experience, and provide facilitated sessions to support educational learning for people with mental health conditions. It's open to anyone aged 18 or over who live in the 4 boroughs or have a GP registered within those 4 boroughs. Talking therapies is something we've got in place and have always had in place. They're going through a review at the moment to look at thresholds and look at the local needs and how we can support that, and looking at linking again with our voluntary sector colleagues and recognising all of the work that they do and the value there as well. To support people with common mental health conditions such as depression and anxiety, one-to-one support, group support is provided. Patients referred there have to have a GP registered within our localities. Then we've also got primary care mental health teams, as we've gone through and we've put in place. They support assessment, triage, but they also support brief interventions as well. They don't support therapy, that's provided by talking therapies, but very much integrated with talking therapies and work hand in hand with talking therapies to support that therapeutic ask as well. And this is people with more moderate potential conditions, probably long-term care, where your complexities are starting to shine through. And then we've got the community mental health teams, who've got your more moderate and severe. And then other than that, it's specialist services that the CMHT will refer to as well. So to access CMHTs would go through primary care. To go through primary care, we've got now mental health practitioners within PCNs who will support appointments, self-referred appointments, contacting through GP practices to support that specialism of mental health focus for GPs to work with. And that's embedding at the moment and expanding as we learn what the needs are. So it's got to be very much focused on patient demographics and localities' needs. How would you get somebody through to those appointments? That you'd phone through, and that's through the reception at GP practices, and they can book appointments directly with those practitioners. Those practitioners will have direct links into formal services if people need that stepped up care arrangements, but they'll also develop really strong links with the voluntary sector. Going through transformation, like I said, it's very much stage 1 has been around our formal internal services. Moving into this year, what we need to do is make the connections outside of formal services, so housing. You have patients who live in your housing that will have severe mental illness and may have teams that manage that. And I don't think, and we recognise that those links sometimes are really disjointed, and that's some of the work for this year we've got to kind of bring together. To how do we do that safely together? How do we support that commonality and provide that provision? I know from an inpatient point of view, we've got lots of patients at the moment who haven't got accommodation, they've lost it for whatever, or at risk of homelessness as well. So there's kind of 2 ways we can support people staying well at home with their mental health illnesses jointly together as a system, and we also need to support people moving out of hospitals into safe accommodations. That frees up patient flow and it makes sure that we can be responsive as possible. But sometimes those links, we need to work together to kind of create those links really. I've put here at the end of the presentation just very much around if you want to have some of because this is a very kind of overview of all of the things that are going on. We've developed a PCN pack which has all of the kind of directions very simply for GPs to follow about what roles we've put in at primary care level, such as care navigation managers, and clinical leads, primary care nurses. What do those roles look like? How do we get support at primary care level? And around the links that you see about the pathways and the contact details are within there as well. So there's a QR code that will take you through to some of the newsletters and videos that kind of explain those pathways a bit more clearer. So I suppose as a whistle-stop tour, that's kind of the pathways that I was going to work through with you today.
That's amazing. Thank you so much. And a lot of information, but a lot of really powerful information. I appreciate you could have had an hour to yourself to kind of deep dive into some of that, Kelly. So really appreciate it. I've just taken a